Hello and welcome to our podcast Public Health Uncoded with Dr. Saroj Pachauri, brought to you by Center for Human Progress in partnership with the POP movement, where POP stands for Protect Our Planet. Dr. Saroj Pachauri, a public health expert, provides commentary on some of the major public health issues of the current times and the various determinants of public health at play with high risk and vulnerable groups. Every month, Dr. Saroj Pachauri, a doctor of medicine and a distinguished public health scholar with over 60 years of experience, will unpack key public health concerns and opportunities in the current global arena with evidence and insights. Now, here is your host, Drishya Pathak. Welcome back. Today, I am joined by Dr. W Townsend, chair of the Rotary Action Group for Reproductive, Maternal and Child Health and the International Center for Research on Women Ethical Review Board. He is a highly accomplished expert in the field of reproductive health and maternal and child health, and has focused on policy development and designing interventions to enhance reproductive health services delivery system with a particular emphasis on clients' rights. He worked together with Dr. Saroj Pachauri at Population Council and held various leadership positions, including the Director of Reproductive Health and Director of Country Strategy. Today is a World Population Day dedicated to focusing on the importance of population issues. Therefore, we will be discussing importance of optimal reproductive health and various aspects involved in achieving it in today's conversation with Dr. Saroj and Dr. John. Sexual and reproductive health and rights as a subject holds a great importance, as there is need to emphasize the empowerment of individuals, especially young women, to overcome hurdles and gain knowledge about their bodies. It is also crucial to understand the evolution of this field from just population development to a broader perspective encompassing sexual and reproductive health and rights. So let's initiate the conversation and hear from the experts who have gained extensive experience in this field over the years. Welcome, Dr. John, and over to you, Dr. Pachauri.
Welcome, John. It is such an honor for me that you have agreed to lead this discussion on the subject of sexual and reproductive health and rights, a subject that is very close to my heart. And you and I have, in fact, worked on this subject for long years. Today, when we talk about sexual reproductive health and rights, everybody seems to understand the concept, but it took a very long time before this concept was really clearly articulated and understood. So what is the origin of this concept, sexual and reproductive health and rights? It really goes far back to the 40s and 50s, when there was a real concern that the population numbers were going up and we needed to control the population. Terms were used like population bomb, population explosion happening in developing countries. There was a concern that numbers were going to grow and we would run out of resources and we had to do something about it urgently. Then in the 70s and 80s, we developed fertility control technologies by which we could prevent pregnancies. And when this happened, and when there were safe and effective technologies for preventing pregnancy, then programs began to be implemented to incorporate those technologies. Now, the concern was really with developing countries, and countries like China, for example, went for a one-child policy. Whereas India, being a democratic country, couldn't do that. They went for something that they called a two-child norm. Now, in order to do that, there was a lot of pressure to reduce population size. And so these technologies had to be incorporated. And India chose female sterilization as the technology. The reason for that was that it had become very simplified. Laparoscopic sterilizations were now being used, where you just made a pinhole, a surgical hole, and you were able to tie the tubes. So it was a very simple method. It was cheap. It was inexpensive. Hospitalization was not required, and it was safe and effective. So there became a huge pressure to sterilize women so that we could control population. Now, what all done with very good intentions, no doubt, but what happened was that the results were mixed. There was a lot of coercion. There was a lot of pressure. There was a lot of force getting women to get them sterilized, and the numbers were increasing, but the quality was very poor, and quality was compromised, and consequently women are suffering from all kinds of complications. So this whole business of ethics, women's rights, violation of women's rights became a concern, and this hit the headlines. And when this happened, women activists and feminists said this cannot be. And so there was a lot of discussion and debate all around the world, starting from the grassroots, going on to the national level, and finally the international level, where in 1994, the International Conference on Population and Development was held in Cairo, and where 179 countries, nations, came to a consensus and signed off on a very forward-looking program of action which placed ethics at the center, which placed women's rights at the center and services around that. So this is how it all began. And today, however, we have sexual and reproductive rights programs around the world. And John, I'd like you to tell us what are the services that are incorporated within this broad canvas of sexual and reproductive health and rights? And who are the target groups, the men, the women, young people, adolescents, especially young people who are sexually active? And how can families and communities address the sexual and reproductive health information needs of these people? Can you say something to enlighten us on these issues, please?
Well, thank you, Saroj. The background here behind me is of a young woman who has to go over a number of hurdles in her life to achieve optimal reproductive health. And we have to follow her over time to make sure that she's actually achieving those goals. The area of sexual and reproductive health is quite broad. It includes learning about your own body in adolescence, learning how to relate to other people, how to incorporate important issues like respect, a sense of autonomy, and interaction with others, including parents and community. It includes being prepared for pregnancy itself, childbirth, and so on through menopause, and I would suggest even post-menopause, in the effect, in the sense that many of the sequelae of problems that occur to women post-menopause are a result of their reproductive lives. So one of the things that happened as a result of the conference on population and development in Cairo in 1994, and later the Women's Rights Conference in Kenya that you referred to, was that we changed the focus of our attention from global population numbers to actually the needs and desires of women, their partners, and their families. I think that was a very important issue because it highlighted some important issues, I think, that relate to medical ethics. So it isn't just technology that we're talking about. We're talking about kind of ethics about how you apply that technology. And there are three kind of dimensions to that. The first is autonomy, respect. People given the opportunity to learn about what's going on, what are their options, where they get it, who the provider is, and do they provide consent? That was an issue that I think people were concerned about with these massive national policies that were focused only on the numbers. The second is, what's the benefit of these things? What's the benefit of the technologies that are developed and services? It isn't just technology, because it's full of range of services, including elements of quality. Do these actually improve people's lives? Are they closer to achieving those goals of well-being that were promised in the Millennium Development Goals? And the third is distributive justice. Who benefits from this? Is this just the wealthy, or a particular group in the West or in the North? Who benefits from this, and how do we make sure that these results and benefits are available to everybody who needs them? So that's the basic criteria looking at this. I think, if we want to begin with young people, one of the ways I think would be to essentially look at UNESCO and WHO's comprehensive sexual education program. It's designed with young people in mind, their needs, but it also incorporates families and communities and schools. It's a evidence-based program that supports increasing knowledge, but not just about sex per se, but it includes information about values such as respect for others, equality, non-discrimination, empathy, accountability, and so on. And it's something that can be delivered in communities around the world. It's translated in lots of languages. It's a particularly good product, in part because it focuses on actual needs of young people. So it believes that if you provide young people with the information that's age appropriate and give opportunities for the people they care about to be consulted, it results in an important benefit to them, both in terms of reducing undesired pregnancies, in terms of achieving the goals they have in terms of marriage and relationships, and it also allows them to think broader about themselves in relationship to their family, their peers, and their community.
Thank you. That's very helpful. Well, in addition to pregnancies and so on, the related subject of maternal and infant mortality, we need to reduce maternal and infant mortality. And words are used like how to avoid pregnancies that are too soon, too late, and too close together. What does that mean?
Well, Saroj, globally, there's about 130 to 140 births a year. There's probably 15% more in terms of pregnancies, because there are about 15% of all pregnancies end up in a miscarriage. There are ways in which analyzing the data to whom these occur, we learn some things. The first is that pregnancies that are too soon, in other words, before 20, more or less have a higher risk mortality on the part of the young woman, and that has multiple dimensions to it. Is it the result of sexual violence? Is it related to some family issue? Is it something that they were aware of? Particularly in places where they've focused on abstinence only, a pregnancy early on usually suggests rape, incest, or not full consent. Too late is an issue that they've begun to look at what are the problems or the challenges of having pregnancies late. And late is commonly thought of as above 35, in part because fertility goes down somewhat yearly after about 30, and also you end up with some additional challenges with multiple births, Down syndrome, and other issues related to later birth. The notion is that the ideal time to have a child, according to the WHO, and the reviews, are somewhere between 20 and 30. It seems to be the ideal time in terms of health. In terms of individual choices, that the range is big. As long as there's consent and a clear understanding about the risks and opportunities and benefits, and people have access to quality of care, then pregnancies are fine whenever they're desired. I think that the third element of that has to do with when the pregnancies are spaced too closely together. The notion is that there should be at least 2 to 3 years between births. WHO recommends at least 2 between pregnancies, the end of a pregnancy and a birth, and the confirmation of a pregnancy, and that's to make sure that the child who's born access to all the benefits of breastfeeding, attention, child development efforts for an additional pregnancy is taken on. The issue around this also has to do with women's autonomy. There are many roles for women beyond motherhood. And if there is sufficient spacing and the timing is set so that women have the opportunities to play critical roles in their family, their community, in the economy, that will ultimately benefit both the woman, her child, and the family.
John, you mentioned spacing. What is the difference between spacing and limiting, and what contraceptives are commonly used by different types of clients? What is the role of men in pregnancy planning? Can you tell us about all of that? These are issues that need to be discussed, I think.
Good question, Saroj. Spacing is essentially the notion that the pregnancy should be spaced, as we were talking about, 2 to 3 years at a minimum, and more depending on what your personal interests are. Limiting is essentially using either a contraceptive or avoiding the sex entirely, to make sure that you have no more children. There are many methods for spacing, and I'll mention a few. And for limiting, there's more than we think. So there's sterilization, as you mentioned, both female and male. There's an IUD or an IUS, which is inserted in the uterus, and it's highly effective. And there are also implants, contraceptive implants, that are on the market. While they are reversible, while the implants and the IUD is reversible, they are often used for simply limiting because they're so highly effective. It's more than 99% effective, and they aren't dependent on on the user's behavior. In terms of sterilization, that's also, as you mentioned, several ways of achieving that, and increasingly they're safer and easier to do, but they are not reversible. So by and large, for men. In terms of sterilization, there's vasectomy, which is actually quite an easy procedure, and it can be done in an outpatient office. It does require training. It's a simple cut of the vas, and it's becoming increasingly popular, and it's used a lot in North America, in parts of Europe and Australia. In terms of spacing, there are lots of methods that have been developed. injectables, lactational amenorrhea for women who've given birth, pills, patches, vaginal rings, a variety of methods that were developed in the 90s and more recently. And those methods may work for a month or 3 months or 6 months. They often require resupply, and that may be a challenge for some people depending on where they live. And because they require resupply and the dependent part on the behavior of the user, they tend to be around 90% in terms of effectiveness over a year. In other words, if 100 women use this method over a year, about only 10 would become pregnant if they didn't want to become pregnant, in part because people use them unreliably. There are other methods that are around for a long time: condoms, diaphragms, fertility awareness methods, and withdrawal, and so on. Spermicides. They're less effective. They have more problems with follow-up, and it gets us to the issue of role of men. In sub-Saharan Africa, for example, young men are the major contraceptive users. 25% of young men in West Africa, for example, use condoms in their last relationship. So while they need to use them with their partner's consent and so on, it's quite remarkable because that isn't what we've seen in many other settings. Secondly, I think support for women's contraceptive use is really important. Being aware of the potential side effects that might occur in the use of the method that the woman has chosen, and thirdly, if there's no interest in additional pregnancies with the partner, men always have the option of vasectomy. So, including postpartum vasectomy, which is a kind of a new concept that's becoming more popular around the world.
And that's a very comprehensive, provided a very comprehensive understanding of the methods. Large number of methods for spacing and limiting that are being used, and men's roles is very interesting, very, very interesting, because by and large, in most countries, that is not the case. Now, we have been implementing sexual and reproductive health and rights programs around the world for some years. The story on fertility has changed significantly. We were talking about population control of numbers, high fertility rates, and so on. The situation on the ground right now is the opposite, in fact. Can you say a few words about that? What is happening actually now?
Globally, the total population of the world is about, or will be around 11.5, I think, by 2100. It's approaching that, but it's essentially slowing down in part because couples want fewer children. In the 50s, the typical family in sub-Saharan Africa would have 6.5 children, two miscarriages, and they would lose some children due to poor health. And so there was a high infant and child mortality. That's changing now, and increasingly, even in places like India, you're familiar. The south of India pretty much has a fertility or number of children per woman similar to Europe, and in some places it's close to Italy, which has a number. The average number of children per woman is like 1.8. The 2 children is the replacement, or 2.1 children is the replacement number. So evening out the births and deaths, if you want a stable population in the world, you'd want to get most countries down to that. But most women now really want to have around 2. It isn't necessarily because that they don't like children or they don't want to have children, but the issue is around timing and the cost of children now. So all over the world, even in rural societies where child labor was a big issue in the 70s and 80s, I think now that many countries are below the 2.5 number, and this is raising the alarm among some traditional patriarchy groups, and they're concerned about labor availability. They're raising a hue and cry about we no longer have people. Well, that just isn't the case, but it is the case that the numbers are getting smaller. And I think one of the things that we want to be paying attention to is the notion of coercion on the part of governments or spouses or families to make sure that women return to a traditional role of mothers to the exclusion of other roles. We saw that in Romania about 20 years ago, when the number of children that was born in Romania per year was dropping off dramatically, and the president said, "No, women have to have children." So they forbid abortion. They wanted to make sure that that women who were working were given pregnancy tests periodically to make sure that they weren't aborting surreptitiously. It's also the case with some ethnic groups. So some countries, including Singapore at one time, only wanted Chinese as opposed to Malay residents, and so they wanted to make sure that there was more Chinese ethnic in Singapore than Malaysians, who they thought were poor and less educated, and perhaps more Muslim than Buddhist. These issues, I think, have by and large failed in the same way that the coercion to not have children has also failed. Individuals have always looked for ways to control their own fertility, and they really resent the acts of governments and churches and others to force them into a maternity that they aren't prepared for.
Well, what about infertility? Can you say a few words about infertility? That's another.
Infertility is an increasingly interesting issue. It has two dimensions. One, there's a concern in the press that exposure to environmental toxins has reduced both men's sperm count as well as women's ability to become pregnant or maintain a pregnancy, and there's some validity to that. But I think it's also the case that there are about 12 to 15% of couples around the world would like to have children, but aren't able to. About 60% of these cases are due to sperm inadequacy, and the rest is to women's health issues. Usually it's thought of as a women's problem as opposed to a men's problem. And so I think anytime we talk about reproductive health, we have to talk about gender and kind of power and who makes decisions. So you're seeing this creep into our discussion periodically. Infertility, the traditional treatments, in vitro fertilization, and others, are expensive, and they aren't available everywhere. And so the World Health Organization and others are beginning to look at that. What are the determinants of infertility? How do people interpret this? In other words, you shouldn't be shaming couples or stigmatizing couples because they don't have children on a regular basis or don't have any. And many women would like to have, or many couples would like to have maybe more than one, or wait 10 years to have a second one. And for them, that's secondary infertility, and they would like to have available options for having that. Now, some of those options may be just timing of sex during the ovulation period. So knowing when ovulation occurs and timing sex at a time to give the greatest chance for becoming pregnant is one way of dealing with that, as well as allowing couples foregoing this complex and expensive IVF treatment that will be increasingly available. Freezing eggs and all that high technology, it isn't available to most people around the world. So the notion is we should be understanding the determinants of infertility more, being more compassionate, being more accepting, and at the same time look for ways in which we might have a better outcome.
Thank you so much, John. You provided a whole array of methods of fertility control, infertility. You talked about maternal and infant mortality and how that can be reduced. You talked about spacing and limiting and role of men and so on, a very broad agenda, which I think our audience is going to lap up. They'll be very interested in what you've said. And you covered a lot of ground in a very short time. Thank you so much, John. Thank you for being with us.
Always a pleasure to speak with you, Saroj, and greetings to colleagues in India and New York.
Thank you.
Sexual and reproductive health are often confused to mean the same thing. While they both deal with sexual wellness, they address different aspects of keeping yourself healthy. Sexual health is needed by everyone, while reproductive health may only be a concern to those trying to have a baby. Reproductive health therefore implies that people are able to have a responsible, satisfying, and safe sex life, and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. It is a public health issue with far-reaching social and economic impacts. Stigma, embarrassment, and taboos surround reproductive issues, making it difficult for women to talk about them and creating a barrier to women accessing the care they need. During today's discussion, Dr. Pachauri and Dr. John addressed questions that are relevant to a broad audience, focusing on reproductive health and related concerns and risk. The topics covered included determining the ideal age for pregnancy, strategies for spacing or limiting pregnancies, infertility issues, the three dimensions of medical ethics, and the use of contraceptives. They also explored global trends in population, using examples such as India, where fertility rates are now similar to those in Europe. The replacement number for a stable population is around 2.1 children per couple. The aim of the conversation was to address the general population's concerns about reproductive health and its impact on relationships. Additionally, they discussed concerns among traditional and patriarchal groups regarding declining fertility rates. However, is the alarm raised about the decline in population a genuine cause of concern? We would like to ask our listeners if they are aware of the population trends in their respective countries and whether it bothers them. Please share your thoughts in the comment section and inform others as well about the changing global population trends. In future episodes of Public Health Uncoded with Dr. Saroj Pachauri, presented by the Center for Human Progress in collaboration with the POP movement, we will delve further into sexual and reproductive health and rights. So stay connected for more insightful discussions.